urban hospitals exploit rural Medicare funds. Is Congress paying attention? Imagine a scenario where urban hospitals are pulling double duty, not just serving patients in bustling cities, but also cashing in on rural Medicare funds. Sounds like a stretch. A new study from researchers at Johns Hopkins University and Brown University reveals that hundreds of urban hospitals have exploited a 2016 policy shift to claim both rural and urban classifications, effectively qualifying for benefits reserved for rural facilities while retaining their urban perks. But here's where it gets controversial. This practice could be siphoning billions in federal dollars meant to prop up struggling rural hospitals. And this is the part most people miss. How did this happen, and who's to blame? Let's break it down. In 2017, only 3 urban hospitals had managed to secure dual classifications. Fast forward to 2023, and that number had skyrocketed to 425. Nearly 75% of these are nonprofit institutions, including massive academic medical centers in major metropolitan areas. Think of names like NewYork Presbyterian Hospital, raking in $9.3 billion in 2023, or the Cleveland Clinic, with $7 billion in revenue. These aren't small, struggling hospitals. They're powerhouses of healthcare. So what's in it for them? By donning a rural designation, they unlock access to programs like sole community hospital status, rural referral center benefits, and lower eligibility thresholds for the 340B drug discount program. At the same time, they keep their urban advantages, such as higher reimbursement rates tied to urban wage indexes. It's a financial loophole that lets them have their cake and eat it too. The policy shift in 2016 wasn't accidental. Courts had ruled against previous CMS restrictions that barred hospitals from reclassifying themselves. Now, urban hospitals can flip their status with ease, and the numbers tell a story. The proportion of administratively rural hospitals nationwide jumped from 27% to 43% between 2013 and 2023. Meanwhile, the share of rural hospital beds ballooned from 13% to 45%, with dual-classified hospitals accounting for 61% of all rural beds by 2023. But here's the kicker. This trend isn't evenly spread. States like Alaska, Maryland, and Vermont have no dually classified hospitals, while highly populated regions see it frequently. The researchers stopped short of calculating the exact financial gains or the impact on rural communities. However, they warn that without policy fixes, more urban hospitals could follow suit, draining funds from the very populations they're meant to serve. Guy Bai, a co-author of the study, calls this a natural response to evolving regulations, comparing it to the 340B program's expansion after eligibility rules were relaxed. With Congress allocating $50 billion for rural health, she questions whether the public realizes that urban giants are piggybacking on these funds. Congress has a duty to close this loophole, she argues. Rural health dollars should help rural residents, not line the pockets of wealthy urban hospitals. CMS Administrator Dr. Mehmet Oz recently announced that applications for the $50 billion fund will open in September. But here's the big question. Is this a smart strategy to stabilize rural healthcare, or are we rewarding the wrong players? Share your thoughts in the comments. Are we doing enough to ensure these funds reach the communities that need them most? Or is it time for a complete overhaul of how we define and fund rural healthcare?